Okay, so ready to dive into this mountain of info you gave me on airway and ventilatory management.
Absolutely. It's a lot to unpack, but I think you got some really good stuff in here.
Well, I tried to be thorough, you know me. But seriously,
Yeah,
it's critical stuff, right? We're talking about those moments when someone's life is literally on the line.
you got it.
Yeah.
And in those situations, knowing your stuff can make all the difference. That's why I like to bring it back to the basics, those ABCs you learned early on.
Right. Airway, breathing, circulation. So are you saying even before we think about bandages or medications or anything else, it's all about the airway?
100%. Because if you don't have a patent airway, nothing else matters. You're not getting oxygen to the brain and the body, and every second counts.
You're really emphasizing that every second counts. In your notes, you even mentioned that case.
Ah, you mean that hiker, the one who had fallen and was struggling to breathe.
Yeah, exactly. What was the issue there?
It turned out to be a partially obstructed airway, some swelling was involved, but let me tell you, those first few minutes felt like an eternity.
And that's with you knowing what to do. So for those of us who might panic in that situation, walk us through it. Say we're first on the scene, someone's injured. How do we even assess the airway? What are we looking for?
You got to use your senses. You're listening for any unusual sounds and looking for any signs of struggle.
Okay, so what kind of sounds are we talking about here? Give me the soundtrack of a compromised airway.
Think of it like a symphony, but instead of beautiful music, you're listening for sounds of distress.
Okay, so not the kind of symphony you want to be hearing.
Definitely not. You might hear stridor, that high-pitched wheezing sound.
Yeah, I've heard that before. It's pretty distinct.
Exactly. That's a big red flag. Or you might hear hoarseness in their voice or gurgling sounds. None of those are what you want to hear.
So those sounds trouble. Got it. And visually, anything stand out.
Yeah, you might see them struggling to breathe, really using their chest muscles. Or their lips might be turning blue, a sign called cyanosis.
Okay, so we've identified a potential airway obstruction. What's our next move? What tools do we have to open things up?
So you've actually got it right in your notes. Jaw thrust maneuver is usually our go-to, especially if there's any suspicion of a neck injury.
Right, protect the spine, got it. But how effective is the jaw thrust, really? It can be surprisingly effective. You're basically just moving the jaw forward to pull the tongue away from the back of the throat, creating that vital space for air to flow. And that's often all it takes.
Sometimes, yeah. But of course, we've got other tools too, OPAs and MPAs, oropharyngeal and nasopharyngeal airways.
Okay, those are in my notes too, but remind me again when we'd use those. So we've got those initial maneuvers down, but what about those situations where even a clear airway isn't enough? I'm looking at my notes here and things are getting serious. We're talking intubation.
Right, sometimes we need to take over the job of breathing for the patient.
Exactly. And it looks like you can't really talk about airway management without talking about intubation.
Absolutely. It's the gold standard for securing an airway in those really critical situations.
And I noticed in my notes here, you really get into the nitty-gritty of intubation. I mean, you didn't hold back.
Well, it's such an important procedure, and you want to be prepared for anything, right?
For sure. But let's back it up a bit for those who might not be as familiar with the ins and outs. When would we make that call to intubate? What are the signs that it's time to take that step?
Okay, good question. Think of it like a spectrum. On one end, you've got someone who's having a bit of trouble breathing, but they can still cough, they can still protect their own airway.
Okay, so they're still conscious, still somewhat in control.
Right, but on the other end of that spectrum, you've got respiratory failure, maybe a severe head injury, situations where the body is just overwhelmed and can't maintain oxygen levels on its own.
So that's when we got to intervene, take over for the body's own systems.
Exactly, and that's where intubation comes in.
Got it. Now, you mentioned RSI earlier, rapid sequence intubation, and my notes are a bit cryptic on that one. What's the deal with RSI? When does that come into play?
Ah, you're right to flag that. RSI, that's a whole other ball game. Imagine this, you've got a patient who's unconscious, airways compromised, and there's a high risk of aspiration.
And just to clarify for our listeners, aspiration means...
Ah, good point. Aspiration means that stomach contents could end up in the lungs, which you can imagine is a recipe for disaster. So RSI is a meticulously choreographed sequence of medications and maneuvers, all designed to secure the airway as quickly and safely as possible, minimizing that risk of aspiration.
Okay, so we're talking high-stakes choreography here.
You could say that.
So let's say we've successfully intubated the patient. How do we know for sure that that tube is right where it needs to be?
That's the million-dollar question, right? We use a few things. First, We're watching for that chest rise and fall with each breath. We're also listening carefully for breath sounds on both sides of the chest, making sure air is getting in both lungs.
So those are our sort of immediate visual and auditory cues.
Exactly, but we've also got technology on our side too. Capnography, for instance, measures the CO2 in the exhaled breath.
So it's like a real-time gauge of whether the patient is actually exchanging air effectively.
Precisely. It's amazing how technology can give us that immediate feedback.
For sure, it's an extra layer of reassurance. But what about those situations where, and my notes mention this too, what about those situations where intubation isn't straightforward, where you encounter a difficult airway?
You're really on top of this. You know that not all airways are created equal.
Well, that's what I'm here for. But seriously, what do we do when we encounter those tricky situations?
Well, that's where those difficult airway algorithms you've got in your notes come in.
Okay, so those are like our roadmaps for navigating those choppy waters.
Exactly. Think of them as our backup plans.
So plan A, plan B, maybe even a plan C up our sleeves.
hmm
What are some of the specific tools or techniques we can turn to when things get complicated? So it sounds like we've got a whole arsenal of tools and techniques to handle those difficult airways.
We do. And that's a good feeling, knowing you've got options.
Absolutely. But I imagine even when we successfully navigate all that, intubate the patient, we're not completely out of the woods yet, are we?
You're right. Securing the airway is a huge win, but it's just the beginning.
So what happens after the initial crisis is over?
Well, then it becomes all about long-term management.
And that's where all this other stuff in my notes comes in, I'm guessing. All those details about ventilator settings, monitoring for complications.
Exactly. We've got to make sure that artificial airway is doing its job, but not causing any harm in the process.
Right, because it's not like breathing through a straw. There's a lot more to it.
Way more to it.
Yeah.
We're talking about fine-tuning those ventilator settings to match the patient's individual needs, making sure they're getting enough support, but also avoiding any damage to their lungs.
That's a delicate balance.
Very delicate. And then on top of that, you've got to be constantly vigilant, monitoring for things like infection, because that tube going into the lungs can be an open door for bacteria, and we don't want any uninvited guests setting up shop.
Definitely not. That sounds like a recipe for disaster. And then my notes mention something about pulmonary embolism, too.
Ah, yes, that's another risk to keep in mind. Pulmonary embolism, that's a blood clot that travels to the lungs, and it can be a life-threatening complication.
So you really do need eyes everywhere, a sixth sense for potential problems.
You got to be proactive, anticipating what could go wrong and being ready to act fast.
It's a lot to juggle. And speaking of juggling, you mentioned earlier that different patient populations can present unique challenges.
Absolutely. One size does not fit all in airway management.
And I noticed you called out pediatric patients and those with obesity in my notes. So what makes those cases different?
Well, with kids, their anatomy is just different. Their airways are much smaller and more delicate, so you need specialized equipment and a very gentle touch.
Makes sense. You can't treat a child like a small adult.
Exactly. And then with patients with obesity, positioning can be really key.
Like that ramped position I saw in my notes.
Exactly. It's all about optimizing the airway, making sure we can ventilate effectively.
Wow, this has been quite a journey. We've covered so much ground today, from those first few seconds at a scene to all the complexities of long-term care. If you had to pick one takeaway, the most important thing for our listeners to remember, what would it be?
I'd say never stop learning. Your meticulous notes and thoughtful questions tell me you've got that covered, but it goes for everyone out there listening. Your knowledge and skills can literally save a life. Never underestimate the impact you can have.
So powerful and so true. Big thanks to you, as always, for sharing your expertise and for reminding us that in airway and ventilatory management, the learning never stops. And to our listeners, keep those brain cells buzzing, keep asking those tough questions, and we'll see you next time for another deep dive.